cultural how cultural brokers bridge divides in healthcare. And this is a project that I had worked on during my time in COVID when I was working at a clinic with a lot of immigrant and refugee patients. And this project has been very dear to my heart because it's been a chance for me to be able to include a lot of personal experiences and learn a lot of new things about the patients that I was working with and will continue to work with. So I hope you guys enjoy the talk, and we will start with a little bit of an activity. Oh. Just a second. Oh, wait. Okay. Oh, okay. Before we get to that. So we are going to talk about a quick case study. So many years ago in this small uptown city, a small town in uptown New York, upstate New York, there was this Vietnamese couple who had an 8-year-old son. And one day they had to rush into the emergency department. It was 10:30, 11, very late at night. The roads were fully snowing. It was hard to see anything, hard to get anywhere. They didn't speak English very well. They were so scared because their son had been having high fevers for 4 or 5 days at this point. And he had been coughing up a storm, and he was complaining of severe backaches. The couple took the boy to the emergency department. And in the emergency department, the nurse took some vitals, had a 103-degree fever. Respiratory rate was a little bit elevated, but otherwise nothing of note. Blood pressure seemed to be in range, heart rate seemed to be in range. But then the doctor comes in and does the physical exam, and he sees this in the boy's throat. What are you guys thinking this might be? Yeah, like strep throat, right? So the doctor, is thinking probably case of strep throat, nothing out of the normal. We'll give him a dose of a course of amoxicillin, and he should be well on his way. So just to, complete his physical exam, he moves on to listen to the lungs, and he lifts up the patient's gown and he sees this. These black and blue marks running like zebra stripes up and down the length of his back. Now, when we see bruising or scarring in a pattern like this, where it is so, geometrically aligned, we are inclined to think that this is an inflicted sort of trauma. And the doctor saw this and immediately thought there was some sort of child abuse case going on. And so he called Child Protective Services. They arrived, they took the son and separated him from the parents. Now the parents, they don't speak very good English, and they had no idea what was going on. They were so scared. Why are they taking my son from me? What is going on? And they were able to eventually get the help of a Vietnamese interpreter who came a few hours later in the middle of the night. At this point, it's 3 a.m., 4 a.m. This interpreter came and was able to hear the situation and realized this was not a case of abuse. Instead, this was a case of coining. Coining is a practice used in Vietnam and other Southeast Asian countries to relieve excess heat that is trapped in the body. This is a healing tradition that many families use, where they take a coin or another hard object and rub it across the length of the back in order to release that heat. And that heat is seen in the form of that bruising pattern. And what the doctor had thought was abuse was in fact a traditional healing practice that this family had used to try and save their son. It wasn't abuse, it was their way of trying to help their son feel better. And because the interpreter was able to be there at this time and help the medical team understand what was going on, CPS was able to give the son back to the parents, and a whole complicated legal situation was avoided. But what if that interpreter hadn't been there? This was 3 a.m. There's not always going to be an interpreter available at that time. What would have been the situation of that boy and his parents had that interpreter not been there? So before we can get into that, I want to talk about what is culture. We talk so much about cultural understanding, cultural competency, and humility. But at the root of that, we need to understand what is culture and what is it comprised of. So what are some of the elements that you think of when you first see the word culture? And shout some out. Food. What else? Music. Rituals, yes. Family traditions, absolutely. Ideas. Oh, that's a good one. Wait, what would language? Yes. All of these, right? Culture is it's such a multifaceted concept. It contains all of these different aspects of life, of society, of living, right? And all of the things that you guys have mentioned are on here. And yet, this is not the whole picture. There is more to culture than what is just listed up here. It is actually an iceberg of sorts. There is several levels to what we consider culture. When we think of culture, we see what is on the surface, right? We see the food and the music and the language and the costumes or the traditional garb or the games that people play, the rituals, all of those things. But then beneath the surface, what we don't see is the ideas that Raymond had mentioned, the way that people communicate with each other, the way that people view social hierarchies, for example, the way that people raise their children, the way that they make decisions. And when it comes into the context of healthcare, this is very, very important. It is so unseen because it is happening under the surface, but it is very much there, and it is very important that we understand that it is there. In other words, there's more to culture than meets the eye. Now let's get into a little bit about cultural brokering. So cultural brokering is this concept of bridging or mediating between two or more different cultures. So in our story that we had heard, the Vietnamese interpreter was sort of acting as that cultural broker. He was acting as that bridge between the Vietnamese family who couldn't speak English, who didn't understand the medical system, who was so confused and lost and scared. And he is bridging them with the medical system, with the hospital, with the doctor who was caring for the patient, with the whole system, with the healthcare system, with the Western medicine as a whole. That was what that interpreter was doing. He was brokering or bridging between these two cultures. And in this context, when we think of culture, it's not just between two cultures in the sense of language or in the sense of nationality or ethnicity. Culture can even be represented by like culture in the sense of the culture of Western medicine as a whole versus traditional healing methods. Those are two separate cultures, but they still can qualify as cultures. So that is what cultural brokering is in a sense. And we see it so often. This is a concept that has been around for centuries, thousands of years. Ever since people of different groups have come into contact, there's always been a need for cultural brokers. Say the Silk Road, right? Back in ancient days, when Europeans came to the Americas and had to communicate with the natives living on the land. This idea of cultural brokership has been around for ages and is present in many different contexts. Like say there's a buyer wanting to buy a house, and so the seller and the buyer need to communicate each other via a broker. Or there's marriage brokers, right, who can help connect two families in order to have a marriage happen. So this idea of brokership is found in many, many contexts. In the context of healthcare, however, cultural brokers are doing so many different tasks. They are helping to connect the patient and provider. They're helping to reduce that mistrust that might be there. They're trying to help build trust. They're trying to help understanding between the two parties. They're trying to mitigate misunderstandings. They might be doing language interpretation. They might be explaining different rituals or beliefs that a patient or a doctor might hold about a certain thing. And they're mostly advocating for their patients and helping them adjust to this new environment, while also being able to retain and hold on to some of their own beliefs and traditions. So now with cultural brokership, we often sort of think of it as something like an interpreter or a priest or a third person that often matches the so-called culture of the patient that is being helped, right? So in our Vietnamese voice story, the interpreter was acting as that cultural broker. So the question arises, does the provider's cultural background actually matter? And does it affect that patient-provider relationship? If a doctor isn't the same culture as the patient, does it make a difference? So there was a study done by Jalil and Freeman. There were two sociologists back in the early 2000s. And they did the study with about 150 people in London and 150 people in Pakistan. And they looked at these different patient-provider interactions. They looked at these different consults, and they had doctors work in same culture contexts and in cross-cultural contexts. So, for example, there might be a British doctor who's working with a British patient, which would be a same culture context, versus a British doctor working with a Pakistani patient, a cross-culture context. And in the same vein, there's a Pakistani doctor working with a Pakistani patient, same culture, and then with a British patient, so cross-culture. And what they found from this study is that culture does actually affect that relationship. Culture plays a role in how the outcome of the visit happens, but also in the quality of care that is provided. So one thing that they found was that Pakistani patients had a very starkly different way of how they viewed their doctor compared to the British patient. So the Pakistani patients tended to view their doctor as an authoritative figure, someone that they had to listen to and someone whose word they respected without question. While the British patients had a more collaborative attitude. They were open to giving and providing feedback or commentary or whatever it may be. And these different expectations that patients hold for their doctors is coming out of their cultural backgrounds, and specifically out of these different cultural dimensions. So there's this Dutch sociologist named Geert Hofstede, and he outlined these 6 different dimensions of culture. And in these different dimensions of culture, it was his way of sort of defining and distinguishing how cultures operate within their daily social lives, how they interact with each other. And in our study, in the Jalil and Freeman study, they were looking at this, oh wait, you can't see it. Let's do this. They were looking at this thing called power distance. And power distance is this descriptor for how patients are able to relate to their doctors, or in general, how hierarchy is respected within a society. So in a culture like those of the Pakistani patients, they are coming from a higher power distance culture where they embrace hierarchy more. And because of that, they're upholding that hierarchical stature more. They're respecting their doctor. They're not wanting to say no or go against their word. And that's actually something that my parents also sort of do. When they go to the doctor, they'll just nod yes. They'll say, yeah, the doctor, like, they say this, but then they come home and they don't do what the doctor says and I'm like, why didn't you just say that to the doctor? And they're like, no, we don't want to say no in front of the doctor. Like, we don't want to upset him because they're viewed as higher up on the hierarchy. And whereas the British patients, they come from this more egalitarian culture. There's that freedom to be able to communicate openly with the doctor and express their concerns or whatever it may be. So that was a really big finding from the study. But the coolest part, actually, was that the best performing doctors were those who were able to become a chameleon. And what I mean by that, chameleon meaning someone who was able to be flexible and move across this power distance spectrum. A doctor who was able to go to a Pakistani patient and adopt this hierarchical or adapt to the hierarchical mindset that the patient might have. And then they go to this British patient, and then they're able to adapt to that egalitarian mindset that that patient has. In other words, they're flexible, right? They're able to adapt themselves according to the patient that's sitting in front of them. That is what makes a great doctor. So that flexibility, that chameleon effect is what really came out of the study. And so the conclusion was that a provider can serve as that cultural broker for a patient as long as they're able to understand where that patient is coming from and they have some existing familiarity with what that patient is needing or is expecting from that visit. All right, now we're going to switch gears a little bit and gonna go over our 4 pillars of medical ethics. So we have all the M2s read our Hippocratic Oath yesterday, so things are relatively fresh in our mind. Beneficence, non-maleficence, autonomy, and justice. So in the context of culture, a lot of times these pillars come into direct conflict. And I'll tell you one story in which that happens. There is a tradition in Haitian culture where pregnant women or women who have just given birth sit on these birthing pots. And these are pots like you see here. They're filled with all these different herbs and they are steaming hot. They are burning they're steaming basically the vaginal area because it's believed to increase blood flow to that area. It's believed to help with the delivery of the baby and to help with the healing after delivery of the baby. And this sort of ritual is very core to Haitian culture. And actually a lot of other cultures around the world as well follow this. However, when there were American doctors or Western doctors that had gone to Haiti and they saw this practice being done, they were very worried. And the reason was that they were getting 3rd-degree burns from these pots. What was the right thing to do? Were they supposed to respect the autonomy of the patients and let them do what their belief told them to do in terms of following this ritual that is so important to them? Or were they supposed to follow the pillar of non-maleficence and making sure that no harm comes to them in the form of these 3rd-degree burns? And that is a conflict that we will all deal with in the future. This is something that comes up so often. We hear all the time patients don't want to take vaccines because of a belief they hold. Or, one thing in Indian culture is, people so often want their babies to be born in a light skin color. So when they're pregnant, they won't take iron or they won't eat dark green vegetables because iron is believed to make the baby be born dark. And then instead they'll take a bunch of saffron instead. And those sort of things, it's like directly affecting the mother's health and eventually the baby's health too. But it's also what that patient believes, right? So how do we navigate those nuances, right? And that's once again with the help of these cultural brokers. They're able to come in and understand both sides and communicate and really bridge that gap and find ways in which both sides can be appeased and help both sides and do what's best for both of them. So this is a quote that I found really poignant. A well frog cannot imagine the ocean, nor can a summer insect conceive of ice. How then can a scholar understand the Tao? He is restricted by his own learning. So there's a story that Swami Vivekananda gave at the Convention of World Religions almost a little over 100 years ago now. And he tells this story of a frog that is stuck in a well. And it's this well frog. He's living in his own well, thinking that it's the whole world, right? He doesn't know anything outside of that well. He's sitting in that well. He's like, this is the whole world. It's great. And one day, this frog from the sea comes and hops into this well. And the frog in the well asks the frog from the sea, where are you from? I've never seen you around. And he says, I'm from the sea. What about you? And the well frog says, the sea? What do you mean the sea? There is no sea. There's nothing outside of this well. This well is everything. This is the whole world. And the sea frog says, well, you have a lot of learning to do then. There is a whole world that you do not know that is outside of your well. And this is the story that I always want to keep in mind when, interacting with patients and really just going forward in life is we do not know everything, right? We're all stuck in our own little wells and we have this idea that all of the stuff that we're learning is everything that exists when there's so much more out there that we do not yet know. And because of that, it's so important that we come into our interactions with people with this humble mindset, right? That we can learn something from every single person that we talk to, especially from our patients. All right, so this is a little bit of a kind of a sad story. This is a story that I had read in this one health literacy textbook. And it is the story of this Navajo grandfather who has a foot infection. His foot has been hurting for the past 3 weeks or so. He doesn't speak English very well. He lives in a small town in Arizona, and his granddaughter lives with him. The granddaughter sees that his foot has been hurting for a long time, but he's just been hiding it. And she offers to take him to the local internal medicine clinic. And so they go to the clinic, and the doctor sees the patient, and he says, "Thank God you're here. You made it just in time. If you had come any later, if you had delayed your visit any later, we would have had to cut off your leg. We would have had to amputate it." And the granddaughter is so pleased. She's like, "Okay, this is great. We brought him in just in time." The grandfather doesn't really understand what's going on. So there's not an interpreter in that area. This was also a very long time ago when, there weren't such strict rules about who can interpret for patient visits. And so the granddaughter was serving as the, I guess, so-called interpreter for this visit. And the doctor said, "Okay, you need to take some antibiotics to cure this medication." Now, this grandfather, he has no concept of antibiotics. In fact, he has no concept of infection, because in the Navajo culture, disease or illness is believed to be caused by evil spirits, or chindis, they call them. And so this concept that there can be a germ that enters a cut and causes an infection and causes the immune system to activate, which can then be, defeated by antibiotics. This is such a foreign concept to him. It makes absolutely no sense. And because of that, there's no way to translate the word infection or antibiotics into the Navajo language. And the granddaughter tries to convey this, but she's unable to. And eventually the grandfather feels so left out of the conversation and just so confused about what's going on that he just says, I don't know what's going on, but I want to visit the medicine man, and I want to do the traditional 9-day healing ceremony that must be done in order to free the evil spirit from the body, in order to get rid of the infection. And the doctor says, "Yeah, I mean, you can, as long as you, get the antibiotics." But once again, there's no communication happening between the grandfather and the doctor. They're both kind of just talking, but not really listening to each other, right? Because they can't, they're not able to understand each other. And so the grandfather leaves, and he attends this 9-day healing ceremony. And it involves sand painting. It involves sand paintings like these, and many chantings. And this is a 9-day process. And at the end of the 9 days, his infection has gotten so bad that he has to go back to the clinic. And the granddaughter takes him back to the clinic that next time. And by then, it's too late. They have to cut off his leg. And the doctor deems it medical non-compliance. That's what he writes in the chart. It's our own experiences that restrict us from considering the possibility that there are experiences and customs and practices and cultures beyond our own that are equally valid. We ought to respect them, but we also ought to share our own, right? It's this balance. It's such a delicate balance, and it's very hard to do. As we see in this story, it's, these sort of tragedies happen when we don't understand, or are not able to understand when or where those patients are coming from. And so when we are able to adopt this cultural broker mindset, or even better yet, actually employ cultural brokers, employ interpreters or priests, or someone who is, well versed in both disciplines, to help in these encounters, we can avoid so many tragedies like these. And a tragedy like that was actually avoided in my own family. This is my grandma and grandpa. So we call her Amama. Um, so Amama, there's a huge history of mental illness on my mother's side of the family. This is my mom's mom, by the way. And my Amama suffered from OCD symptoms, depression symptoms for a very, very long time. And back then, especially in India, like no one really knew what mental illness was, right? They didn't think of it as, a disease of the brain or a disease of the mind. It was rather seen as, evil spirits have taken over your body, or you're possessed by a demon, or even sometimes like the goddess or God is possessing you and, wanting you to do certain things. They're carrying out their mission through you. And that was actually kind of what happened with my mama. Her state was so bad for 20 years, she wouldn't be able to get out of bed. She would go to the shower and shower like 10 times. She'd wash her hands nonstop. She had scars all over her hands. She was scared to leave the house because of all the germs that are out in the world. And she was so scared to talk to anyone. And she was also hearing and seeing things. She was hearing the voice of the goddess Amoru. This is this is the goddess she's the main deity in the city of Vijayawada, where my family is from. And my mama was hearing the voice of Amoru in her mind. And Amoru was telling her, be careful, don't go out there, don't do these things. Make sure you're staying clean. You have to stay clean in order to worship me. You have to do these things. And Amama didn't see that as something to be treated, right? Because it was a blessing to be receiving the messages of God. Why would you treat something that's a blessing, right? And so because of that, she never went to go and seek treatment. She went 20 years without ever seeking any treatment. And because of that, she suffered a lot. And the rest of her family also suffered a lot. My mom and her two sisters, they didn't have a normal childhood growing up because my grandma was always in bed. And so they had to take care of the whole house themselves from a very young age. My mom started, doing these chores on her own, like from the age of 3 years old. And it wasn't until much, much later that a friend of my tataya knew a psychiatrist who came from the same village as them and understood, these religious sentiments that they hold, and even had family members who suffered the same thing that Amama did. And Amama finally agreed to see the psychiatrist, and he was able to prescribe her an antidepressant, and her life literally changed. Like, she is such a different woman than she was way back then, according to what my mom has told me. Like, it's, she's actually able to, like, she's able to leave the house. Actually, she's able to come to the US and see us, like her grandkids, and all because of that doctor who was able to communicate with her and understand where she was coming from. And he told her, you don't have to see this antidepressant or this medication as getting rid of God from your mind, right? It's just helping you achieve what God wants you to do, but in a healthier way. You're not getting rid of God. You're just making it easier to live out that mission or whatever that purpose is. And those symptoms still are there. Like, she's still very picky about us not touching the fridge, and we have to wash our hands everywhere. And there's certain rules about like inside clothes, outside clothes, and everything. But it's definitely like 100 times better than what it must have been back when my mom was a kid. So that's the story from my very own family, where that cultural brokership has made a difference in not just her life, but in the life of our entire family. All right, switching gears a little bit. Talking about vaccine hesitancy, this is something that we've been seeing, especially in the last few years, ever since COVID has started, right? One thing that we've heard is, people from the Muslim community are scared to take the vaccine because it has components of pork in it. Or people from the Catholic community are scared to get the Johnson & Johnson vaccine because it was developed with cells that came from a stem cell line from aborted fetuses. And there's all these different cultural aspects that often go unheard when we are thinking of vaccine hesitancy. we don't actually necessarily always understand the reasons behind why they're not wanting to get vaccines. And this is where cultural brokers have really made a big difference. You know, these are members of our communities who have stepped up to communicate and bridge that gap between the medical community and these communities. There's this pastor in Florida who gave a sermon to all of the worshipers there, to the congregation, about how receiving the vaccine is part of doing God's work, because you are helping your neighbor, and helping your neighbor is God's work, right? So even if the vaccine has these components, you are still doing your duty and, you know, fulfilling your religious responsibility. There is this Imam Wazir, who communicates about the vaccine and gives information about the vaccine in 6 or 7 different languages. A lot of people don't necessarily speak English, right? And not only English, but also a lot of this information is not necessarily in lay people terms, right? So it's already hard enough to understand in English. And so now imagining you don't even know English, it must be even more difficult. So Imam Wazir, through the IRC, was able to make many YouTube videos about how the vaccine can help you, your family, your community, and how it wouldn't be going against what God would want or what the religion would say. And even with the Catholic community, the Pope Francis himself actually had said, even though this vaccine may come from stem cell lines that are from aborted fetuses, it doesn't matter because it's so far removed. And the good that you would be doing by taking the vaccine and protecting the people around you far supersedes the sin that would come from taking the vaccine because it is associated with those stem cell lines. So really, when these religious leaders in our communities are able to step forward and help bridge this gap, it does so much good in our communities. And we've seen this firsthand in these past few years with the pandemic. How am I on time? Okay, okay. All right. Okay, so now this begs the question, does a provider have to share the same culture as their patient in order to be a good cultural broker? Or can the provider come from any culture and still be able to relate to their patient? This is the age-old question, right? And the answer is it's really kind of a mix of the two. There's this study done by Melanie Carilion and Jan Garcia. They were these prominent sociologists back in the 90s, and they published this huge paper about cultural competency versus cultural humility. And what's the difference between they both sound kind of similar, right? But cultural competency implies that you've already learned everything there is to learn about a culture. You're competent, you're there, there's nothing more to be learned. But that's not the attitude we want, right? We need to adopt a mindset of cultural humility. There is always something more to be learned. We cannot possibly know every single thing there is to be learned about a culture, or even about the different subcultures within that culture. And then even deeper yet, about every single person within that culture. Even within a culture, there are so many people who have different differences and in the way they practice that culture and in the way they relate to each other, right? So really adopting that attitude of cultural humility, this willingness to learn about the patient and their unique circumstances, is what makes a good cultural broker. They're able to balance that competency with humility. And a perfect example of this is the story of Lata Pancha. So she was this M3 student. I don't know from which school. This is from a podcast I had heard, but this happened about 10 years ago. And she was an M3 student, kind of like a lot of us about to begin our rotations. She was very, very, very scared about starting her IM rotation. And, you know, she was going through all of these rotations kind of with the mindset of, you know, I have to get a good grade, like I have to do well, I have to impress my attendings, I have to finish all these notes and charting and this and that and everything, right? And she felt like she didn't have the time to actually spend with her patients. She was losing the thing that mattered most. And there was one patient that changed that entire thing around for her. And it was this elderly Toisanese patient who came in with osteonecrosis of the jaw, and he had to get surgery for it. Pre-op though, he was in the hospital for a few weeks. He didn't speak any English. He only spoke Portuguese. And Letta had no way to communicate with him. There was no Portuguese interpreter in the hospital at that time. This was once again a long time ago. And she knew that there was, he wasn't getting, no one was really going in to see him. He was just always looking out the window and just, in his own little world. And Letta wanted to get to know him. And she started going into his room and, just spending time with him. Even though they couldn't communicate with each other through language, there's still his presence there, that was making all this difference for him. And eventually it got to the point where they were able to sort of sign to each other. She would ask, does it, where, does it hurt anywhere? Does it hurt here? Does it hurt here or here? And he would start pointing to different places on the body. And she'd say, hungry? Are you hungry? Or are you thirsty? Do you need to sleep? They started building this own language of theirs. And eventually she decided to even write these different words down on a piece of paper along with images so that he could better understand and he could point to the image of what he was feeling. They built their own dictionary to be able to communicate with each other. And eventually he went into the operation theater. The operation was a success. He came out. His family had finally come to see him. They were elsewhere, not really sure what the situation there was, but they were finally able to see him. And the day he was leaving, he holds her hands and he says, thank you. He learned those words, thank you. And, it's interactions like that it seems so special. And I'm so looking forward to be able to, have interactions like that with patients in this next year and beyond. And, this story really goes to show, even if you don't come from the same cultural background as a patient, that is not stopping you from being able to connect with them and make a difference in their lives. And this is another story that was also very, very special. And if you don't mind, I would like to read an excerpt from my book about this story. It's one that's very, very special. So in May 2021, a 56-year-old a Muslim woman called Bivatu was admitted into the COVID-19 ward at Sayana Hospital in Palakkad district of Kerala, India. Bivatu, who was critically ill from COVID-19 related pneumonia, was placed on a ventilator for 2 weeks. None of Bivatu's family or friends were allowed inside to see her due to COVID-19 precautions. And as a result, her doctors were the ones to take on that role of comfort and support that her family would have otherwise provided. For over 2 weeks, as Bivatu underwent treatment and ventilation, her son and son-in-law would come to the hospital, ignoring heavy rains and lockdown restrictions in order to check on their mother. Even though they weren't allowed inside the hospital, they waited for hours in the parking lot just to see the doctor and to inquire about Bivatu. They knew her condition wasn't going to improve, yet they came daily to meet the doctor and to get some peace of mind that she was in the right hands. But Bivatu's condition continued to deteriorate despite her ventilation support. By May 17th, her organs began to shut down. The doctors were afraid there was not much left they could do for her at this point. After discussing with Bivatu's family, they made the difficult decision to take her off the ventilator. Her doctors stood around her helplessly as Bivatu gasped for air. One of her doctors, Dr. Rekha Krishnan, sensed she was struggling during her last moments, unable to leave peacefully. Though she was Hindu by faith, Dr. Krishnan leaned forward and softly recited the Islamic Kalma Shahida prayer into the patient's ear. This prayer is traditionally recited by Muslims at the time of one's death in order to ensure a peaceful transition from life. What touched Dr. Krishnan most was that as she uttered the last words of the Shahida, La ilaha illallah Muhammadur Rasulullah, Vivatu took her last breath and flatlined. The way this happened made me feel that someone made me do it, like a divine intervention, Dr. Krishnan shared. If her daughter or a family member was there, they too would have done the same thing. It was not a religious act, but a humanitarian one. Dr. Krishnan, though she was born in Kerala, was raised in Dubai all her life. She grew up in and around cultural diversity as she fasted both for Mandalam, which was a 41-day period of prayer in Hinduism, as well as Ramadan, a month of worship and remembrance in Islam. She knew the customs and practices followed by Hindus and Muslims alike. I was never discriminated against because of my faith when I was in the Gulf, and I returned the respect when I got a chance, he said. Chanting the Kalma was a normal thing I would have done any other day if needed, just like a family member. So at the end of this, there's once again this beautiful quote by Anne Fadiman in the book The Spirit Catches You and You Fall Down. And it's a wonderful book to read, by the way, if you're interested at all in this topic of culture and medicine. She says, the action most worth watching is not at the center of things, but rather where edges meet. And in what I've come to understand what she means by this in the sense of cultural brokership is the people that make the most difference are not always in one circle or in another circle completely. They're living at the edges where they're able to bridge between two cultures, these different groups or these different circles of people. They're often encompassing multiple different groups and, stretching across different communities and bringing them together. And it's the edges that I feel we should strive to be at. And so, if anything to take away, living on the edge, and not in that sense, but living on the edges. And with that, I'd like you guys to, when you go home, just think about this and how you'll act as a cultural broker for your future patients. And I'd like to thank you guys for joining. You to take questions now.
I'm so glad you told that story about the third-year student, because as you get on the wards, I mean, you'll be the ones that have the time to go back and talk to the patients. A lot of times the doctors aren't. Those of you who've been there know. And just, that's where the richness will be, when you go back and just, many times you will share a language and you can just sit down and say, tell me your story, and just get to know the patients on that level. And it'll make your experience so much richer, but also you may find out things that the team didn't know because you spent that extra time with them. I thought that was a wonderful presentation. Thank you. I guess my question, it's, you were talking about cultural humility, and it seems a little overwhelming because there are so many different cultures and different things under that iceberg, to be able to, in the brief time you have with the patient, to be able to connect on that level. I don't know, I'm not asking for an answer to how you do it, but I think just the awareness that how important it is at least the first step, because we don't have these cultural brokers that can tell us, these things when we interact with patients.
Yeah. It's definitely,
unfortunately, we have so little time to connect on that level.
Definitely. I feel like there is definitely a lot of work to be done in this sphere. And actually, there is a cultural brokership program that is being built in Canada right now. And we're doing a lot of research into this, but we still have many ways to go before we can actually get cultural brokers implemented into our healthcare system. So until then, we'll have to take on that role. And we're already doing a lot. There's so much put on the plates of doctors. We already have such short visits and so many things to cover in such a short visit. So in my opinion, I think it really comes down to how we make the most of those few minutes that we do spend with the patient, and really trying to understand their story, as it all always comes down to.
Great talk, Sneha.
Thank you.
Can you talk a little bit about how you came to find different stories that ended up being included in your book?
Yes. Oh, so this book is really a compilation of a bunch of different stories that come from a lot of different places. So some of these stories, as you've heard from my own life, either from my family or from the patients that I've gotten to work with. Some of the stories that you've heard today are from textbooks or journal articles or even newspaper articles that I did for research for my book. And then still some came from interviews that I did with physicians or med students or other people working in the healthcare field. So really a mix of those.
Thank you again for coming and talking to us. This was really a fantastic talk. We appreciate it. Just reflecting on what you were saying earlier about the role of physicians as potential cultural brokers, and how you had mentioned that some of the best physicians are ones that can be cultural chameleons almost. I was hoping you could expand on that idea a little bit, because it seems like it's difficult to strike that balance of being a cultural chameleon unless you are very competent within that cultural community. So I was hoping you could kind of share your thoughts on that. Is that something for people who have a multicultural background? Or is that more people to like a goal to strive towards almost?
That was a great question. So in that study, it happened to be the multicultural doctors who were more able to adopt that chameleon effect because they've been doing it their whole lives, right? They, are living one culture at home and they come out into the workplace or with friends and they're living different cultures already. And so that shift, I guess, they're able to implement more easily in their workspace. But I do think for all of us, it is a goal to strive towards. Not necessarily, it doesn't have to just be cultural chameleonship. I just made that word up. But even I think it just really comes down to understanding the patient that is sitting in front of you and recognizing that that patient is not going to be the same as the next patient or the next one after that or the next one after that. And I think being able to adopt that chameleon mindset definitely comes from I think like longitudinal care with that patient. The more time you spend with them, you're able to understand those nuances better. And I think also with experience, years of experience of being a doctor, I think we'll hopefully get better at that skill. So.
My question's going to make Dr. Morrow proud, but how do you build systems that might be more hospitable to like cultural brokering within that system?
Oh, that is honestly the hardest part of this, is being able to implement it within the system we already have. So actually UCSF, UC San Francisco, has a very, very preliminary version of cultural brokership. They call them cultural ambassadors. So there's an example of a family who will come to UCSF for an operation. They're from Saudi Arabia and they're able to hire a cultural ambassador to come and help them throughout the process. But the problem is they're really expensive and a lot of people don't necessarily have the means or resources to be able to do that. And so then the question comes, does the hospital should maybe provide that? But once again, hospitals are, dealing with their own resource allocation issues. And so then I think the closest solution I found is partnering with local community organizations to implement that cultural brokership. So the way we've done that through the COVID-19 pandemic, where, the local governments are partnering with community organizations and religious leaders to be able to get messages across to those communities. So I think maybe something similar to that, where we can, directly, take from the community and give back. That's what I'm thinking, but I'm sure there's other ideas out there.
So I want to bounce off of that point, because I think a lot of us have worked in the Department of Public Health, and there are local outreach programs currently for different immigrant communities, right? So that cultural brokership it seems to be starting to occur. Now, from your perspective, is this more a new phenomenon where we're finally seeing resources being allocated to those programs? Or is it just that we've been very slow to do this in an effective way until now?
Well, that's a great question. I honestly, I think it's more of a new phenomenon, or at least we're recognizing that this is actually a thing and we're starting to make changes towards this. Like even the term cultural brokership wasn't coined until the late 90s. And so it is a relatively new aspect in general. And then when it comes to healthcare, it's an even newer sort of concept. But that being said, there are great strides being made. And I think not just in a personal individual level, like individual cultural brokers helping a patient provider visit, but even organizationally, right? Like with Blue Ridge Literacy, they're teaching immigrant and refugee students, adult learners, to be able to convey their health information effectively to their doctors and helping them feel empowered to carry their health information with them instead of having to depend on someone else. So I think definitely we are making big strides towards that, both individually and organizationally.
Just to jump off of that, but I just wonder if, instead of having kind of like consultant broker kind of, roles, instead trying to systemically like disseminate, an understanding of other cultures, through like training and medical education and everything. Obviously that puts the burden on those populations oftentimes, but I wonder if, because you said like each patient is different, but I think understanding kind of like those kind of stories that underlie various cultures, understanding those and disseminating that across training may be less of a resource burden than individual brokers that, for example, like
Absolutely. And I think that's where, putting resources and investment into, like the diversity organization of medical schools makes a big difference. We're able to give training like this to medical students. Actually, all of us now soon to be M3s had gotten to talk about cultural humility way back in our M1 year, and continuing to have talks like that. And I think definitely sharing stories makes a big difference, as opposed to kind of just having a textbook sort of format. This culture does this. Actually, there was a nursing textbook, I think back in 2018 or 19 that got recalled and like taken off the market because it had really insensitive things written about different cultures. And it was just trying to, I guess, the intent of the textbook was to try and convey, like, I guess, information about different cultural groups, but it got to the point where it was like making stereotypes about them. And I think that's the balance that's very hard to achieve when, training in this sort of topic. Like, for example, there's one instance of a Muslim provider who's treating a Muslim patient who has hypoglycemia, and the provider automatically assumes, oh, she must be fasting because it's Ramadan. That's why she has hypoglycemia. When in fact, she had not been fasting because she was already suffering these symptoms. And so I think it's very, very easy to fall into those stereotypes, and it's a very dangerous territory. So that is something, once again, that these trainings hopefully can teach us to avoid.
All right, if we're good, then I promise last question. On the topic that Marina just brought up with medical education specifically, we talk a lot about how we try to incorporate more cultural humility into the medical school experience, but simultaneously, by necessity, American medical schools focus on creating a single type of doctor, right? So there's that hidden curriculum that's always baked in and move fast and be efficient, right? I suppose what I'm asking you is, what room do you see, at least in the medical experience, for improvement, for creating doctors who are better at being cultural brokers?
I feel like our school's doing a very good job. I think even just having platforms like this to be able to share stories, having those talks that we do throughout M1 and 2 year, I think those are very good steps towards achieving that. I think really just making sure that, people have this space to be able to share their experiences, and then others are able to listen and learn from them. I think that's the best way to move forward.
Thank you.
maybe I got one more comment, just bouncing off of that. Do you think that do we have enough forums for, like, your lived experience is so rich, and I've learned so much from your own personal stories. And I'm sure, you know, many of us, you guys have wonderful stories and lived experiences. Do you think we do enough to have spaces to learn from each other in this way?
You know, that's actually something I've been wondering about. You know, like we've all written such amazing, like talked about our experiences in such amazing ways in our admissions essays to be able to get here, right? And it's kind of a bummer that we don't actually get to hear them, you know? So I mean, I know we had done something like a very small version of that in HSSIP, but I think it'd be really cool to be able to have a session or two in HSSIP to be able to share like meaningful experiences like these from people's own lives and learn from them.
Submit to the articulation journal next year.
I'm gonna double down on this point. All of you have had an M1 mentee at some point. Reach out to them and tell them that they need to think about something for them at MSGR next year. That's, I absolutely agree. I think that's a fantastic presentation.
Thank
you.
I'm really happy to, you know, have this platform to be able to share this. So really grateful to you guys for helping to this on. So thank you. Oh, oh, I'll see that it's got a scan the barcode for my book.
Oh, yeah, just bring your book with you.
Oh, yeah, I have it.
Thank you.
I have it here.
I'll sneak us taking her photo. Thank you all for coming and joining us.
Let me get closer.
We did sign in earlier. Please sign in.
Oh,
And feel free to take more food.
Oh,
Thank you all for joining us on Zoom as well.
Reiterating David's point, if you haven't signed in, please sign in.
Yes.
If you have gotten food, please get food.
Please sign in. And for those on Zoom, thank you for joining us. And please look forward to more talk.
It was uplifting, informative, encouraging, and just beautiful. It's fine.
It's gonna be all right.
You should be so.
One way or another.
Oh, I need to- I should probably take my mic off for that.
Yeah, but that was recorded.
Mhm.
Yeah.